Class begins now. So this session we're going to talk about something a little bit different. We're going to talk about nutrition and your brain with Dr. Neil Nedley. Dr. Nedley is a physician in internal medicine with an emphasis on gastroenterology, mental health, lifestyle medicine, and the difficult to diagnose patient. He has provided continuing education courses to physicians and health professionals around the world. He's also given numerous health education seminars to the general public, and those audiences are everywhere worldwide and right here in our hometown of Rochester, Minnesota. Dr. Nedley is the author of the book Proof Positive: How to Reliably Combat Disease and Achieve Optimal Health Through Nutrition and Lifestyle, now in its fourth printing, I might add. And this book tackles heart disease, cancer, hypertension, diabetes, kidney failure, high cholesterol, and many other diseases, providing common sense, important, nutritional and lifestyle therapies that can make a sustainable difference in treatment and or prevention of these common conditions. And of course, all of these things are essential. They're all part of lifestyle medicine, and that's what we're here to learn about today. So Dr. Nedley, please take the stage.
Should try it. Speak.
Testing?
Yeah.
Okay, there we go. Yeah, thank you. It's good to be back in Rochester, Minnesota in person. I think it's been just 3 years since we were here last time, but a lot has happened in 3 years. And I'm sure many of you are aware that it's being actually discussed that there are two pandemics. There's the pandemic of COVID, which has kind of become endemic and on the descent. And then we have something that seems to have had a greater impact, at least according to Gallup and a lot of other studies, and that is the mental health pandemic. And the mental health pandemic, actually, as far as consequences and things, seems to actually be outweighing the pandemic that gets most of the attention today. And out of all of the things that I do and was mentioned and written about, because this mental health pandemic has become so significant, and also the fact that traditional forms of therapy have their limitations on the mental health aspect of things. Testing. Okay.
There you go.
Okay. And so with that, with the fact that traditional therapies seem to have their limitations, and of course, many times people that surface the emergency room, you'll see this in just about every ER in the country. You're going to see individuals that are there maybe for their 6th, 7th suicide attempt, on a hold waiting to get into a psychiatric institution and go through the repetition process. And often that's when they hear about us and hear about our program and the approach. And so then they're sent to a whole different type of residential facility in regards to really trying to get to the real cause of their mental health issues. Fortunately, what we have done has gotten some. Of course, we've published a lot in the scientific literature, but on top of it, the state officials have also seen the significant before and after difference in a lot of individuals. We've also developed an emotional intelligence curriculum for the college level, and recently we've been asked to write a K through 12 curriculum for the public school systems. Particularly in the U.S. territories, Guam and those 10 islands. And we're actually piloting that there now. And now they've asked us, before they just asked us to do 1/4 but the feedback has been so well received that they're wanting us to actually develop a curriculum for every grade where every person there has to take, just like you take math every year in public high school, and you take social studies, and you take science and English, that this would be part of the required curriculum of improving emotional health. And often people aren't learning about this even in 1/4 of work in public high school. But with this being such a great problem in our world today, it stands to reason that we should start changing our educational curriculum to start focusing in on it. But today I'm going to be looking at nutrition and neuroplasticity, and although we also run community programs, outpatient community programs, in fact, well over 10,000 individuals have gone through our outpatient community programs. Our residential program is the one that I'm intimately connected with on the medical side of things. And so I'll talk a little bit about what happens on the residential side when an individual comes to our program, because we really want to turn on what's called the positive neuroplasticity switches. The brain has to change. And the amazing thing about the human brain is that it is capable of tremendous change. No matter how bad an individual feels and how stuck they think they are, if they have a frontal lobe of their brain can be tremendously transformed. And many of our individuals, 20 weeks after the program, will say, I don't even know who that person was that came to that program. I realize I was that person, but I'm so different now in so many positive ways. And one of the ways, of course, is the nutritional element. And so we're going to talk about excess calories. Often we talk about things that we can eat to help us, and we'll be talking about that as well. But a lot of the problems in today's world is actually excess calories. It reduces synaptic plasticity, increases the vulnerability of cells to damage by causing free radical formation that surpasses the buffering capacity of the cell. This is one of the reasons why longevity has been decreasing some in our society today. A lot of it has to do with the mental health part as well. But we'll never solve the obesity epidemic in our country until we solve the mental health issues behind it, because often people are eating in order to self-medicate for their emotional issues. Caloric restriction, moderate caloric restriction, could thus protect the brain by reducing oxidative damage to cellular proteins, lipids, and nucleic acids. And one of the major focuses in recent years has been on ketogenesis. When we actually fast, our body starts to produce ketones, and this is not just another form of energy or a way we can get energy. But we now know that it enhances the body's defenses against oxidative and metabolic stress. It also initiates the removal or repair of damaged molecules. And this carries over into the non-fasting period as well. So when we are not fasting, our glucose regulation is improved. When we undergo regular ketogenesis, our resistance to stress improves, and inflammation also improves significantly. And depression and anxiety is often thought to be an inflammatory disease of the brain. That's why we measure everyone's inflammatory markers when they come as well. In fact, it's been shown that if you have a C-reactive protein of 2 or higher, your risk of suicidal thoughts dramatically goes up because of that inflammation in the brain. And so ketogenesis will actually be one of the ways in which we can bring down those inflammatory markers. And it's also been shown to improve mental and physical performance. And so some people actually have recommended we go into ketosis just by changing our diet and getting rid of carbs in the diet. But that is not the healthy way of doing ketogenesis. And I'll explain that in a little bit. We actually need carbs. We need an insulin-mediated mechanism to actually get tryptophan into the brain. And tryptophan and tyrosine are needed to make very important neurotransmitters of serotonin, dopamine, and norepinephrine. And so we don't want to get rid of carbs. Natural carbs have actually been shown to be very healthy for mental health. But we do want to be able to get carbs with ketogenesis. And that produces a win-win situation. So how do we produce the ketogenesis? Well, for many, this isn't all. It's not a one-size-fits-all approach that we utilize in our residential program. But after we do our initial evaluation, I would say probably half of the individuals that come to our program, maybe a little more than half, are actually put on a fast. They're coming to a residential program to get better for mental health, and they think their mental health is going to be worsening now because they're actually being put on a water fast. Now, we help them through this process. We have a medical team there. Many individuals have never actually skipped more than one meal their entire life before coming to our program. And so they think, how am I going to be able to live? I mean, I'm sure my blood sugar is just going to bottom out and I'm going to have all of these problems. And we tell them, well, we have nurses standing by. If you have issues, you can come by the clinic. And amazingly, these individuals do so well that we virtually never see them in the clinic. In fact, after that, for many of them, it's a 36-hour fast. After that 36-hour fast, they're saying, that wasn't bad at all. I'm just amazed at how I was still able to exercise. I was still able to perform. I was still able to come to class. I was still able even to do the circuit training and exercise, and I wasn't eating. And now I'm starting to feel better. Well, there are reasons for that. So fasting does several things. Sirtuins, or I should say, sirtuins are guardians of the genome. And sirtuins actually go up with fasting. So they're actually going to help preserve us. There's many anti-aging effects of fasting that occur. AMP-K, or AMP-activated protein kinase, restores energy, and that is activated by fasting. mTOR goes down. mTOR promotes inflammation, and it's been shown to reduce longevity, and fasting decreases mTOR. The ULK complex activates autophagy, which is the body's way of cleaning out damaged cells in order to regenerate newer, healthier cells. So kind of imagine the body as being a construction site. For those of you that have been on construction sites, when the house is being built up, or the business building or whatever, there's a lot of dirt and a lot of debris that are accumulating around that construction site. And you don't go in there and clean that up as it's being built. After the contractor is through, often he'll have a team to actually come in and spend some time cleaning that up afterwards. But building isn't going on when cleaning up is occurring. And our body is the same way. When we are in the eating mode, we're in the building mode. We're supposed to be in the anabolic mode. But if we don't ever pause and rest, we actually don't have the ability to clean out our damaged cells or regenerate newer, healthier cells. And so our bodies were actually designed for periods of fasting for good health. So fasting has been shown to inhibit the effects of aging. It regulates T and B cells, so it's an immune modulator, helps the immune system. It's been shown to reduce the risk of cancer, diabetes, obesity, and now recently Alzheimer's, or age-related cognitive decline, can be enhanced as well through regularly undergoing ketosis. Many of the beneficial effects of caloric restriction and fasting are mediated by the nervous system. Intermittent fasting results in an increased production in brain-derived neurotrophic factors. So this is something we can actually measure in the blood pre and post. BDNF is a brain fertilizer. It helps us to learn new things. It actually is thought of as a natural antidepressant. In fact, the newer drugs that are coming out in the market, they're all doing pre and post BDNF levels, because if the BDNF levels come up, that drug is going to be a lot more marketable as a result. And BDNF also increases the resistance of neurons in the brain to dysfunction and degeneration. They've even done studies on very difficult professions to learn a lot of complex things, like becoming a pilot of a 787, a Dreamliner, and all of those things that pilot has to go through. If their BDNF levels are high, they're going to do well in those courses. If their BDNF levels are low, they're going to struggle, and they're going to have to do repeat tests and all sorts of things as a result of that low BDNF level. Resting our guts periodically through daily fasting triggers a cascade of hormonal events in our bodies which boost our body's repair mechanisms. And BDNF starts to go up with as little as a 12-hour fast, and can even go up more with a 17-hour daily fast. And so what we'll do with these individuals after they're on their 24 or 36-hour fast, and I should mention, we have at Weimar, it's now called Weimar University, it used to be Weimar Institute. But at Weimar University, we have a mental health residential section, and we also have a physical health section for cancer patients and advanced coronary disease patients and a lot of chronic diseases. Often these individuals are people that have had multiple bypasses, and they've ran out of saphenous veins, and they've got recurrent atherosclerosis, and they're on death's door, and that's when their doctor will say, have you ever considered going to Weimar? We don't have any other veins we can use to bypass what's going on. And so their backs are against the wall as they come there. And in that physical program, we'll often actually have them go through a 72-hour fast. And that actually is pretty easy. I mean, it's not as easy as a 24 or 36-hour, but the 72-hour fast is something that's actually been shown to be very healthy. If you fast for over 12 hours, metabolism of fat stores release those fatty acids called ketones, which improve memory learning and reduce neurodegeneration. And prolonged daily fasting reduces the risk of breast cancer recurrence. By prolonged daily fasting, we're talking about eating breakfast and lunch and no supper. And so on a no supper program, and then sleeping without food, it's very easy to maintain your weight. Obesity is almost unheard of because what we eat in the evening does tend to turn into fat more. There now has been some very interesting studies away from mental health on the 72-hour fast, and it's been shown to protect bone marrow cells from chemotoxicity. And they're now starting to utilize this in cancer patients. One of the issues of chemotherapy is that it kills off our bone marrow cells, our rapidly producing cells. And this is something where we have to weigh the benefits versus the risk, because you can have your cancer cells being destroyed by chemotherapy, but if your immune systems are destroyed, you can actually die from an infection before you die from the chemotherapy as a result, and it becomes very cautious, a week afterwards and all of that when the white blood cell counts drop to nothing. And interestingly, 24 hours doesn't do it, 48 hours doesn't do it, but if you do a 72-hour fast before your chemotherapy, your white blood cell count will be maintained. In other words, the body's repair mechanism and protective mode that results from fasting protects our healthy white blood cells from the chemotherapy, but it doesn't protect the cancer cells from it. And so the cancer cells are destroyed and the white blood cells are maintained. And this is very exciting. This is a lot better than having to take all the shots and things to try to get your white blood cell count up, and it can make a foundational difference actually in being able to fight cancer. 72-hour fast also promotes stem cell-based self-renewal to reverse immunosuppression, and so it has a very positive effect on stem cells, and it down-regulates insulin growth factor, which also is implicated in a number of cancers. The more IGF-1, the more that cancer is going to tend to grow. And so what they'll do in our program, after that 24 to 36-hour fast, we'll then put them on a no-supper program. So they'll be on breakfast, which will be a very healthy breakfast. They'll be on lunch, a very healthy lunch. We're in the lunch a little bit later. It's about 1 to, they're finished eating by 2 p.m. But those meals are so healthy that after a few days, they're not missing their supper. Even right away, they're not missing it. Part of the reason is they started out with a fast. And so they've already been used to fasting at least that one time. And so to go without eating supper is no problem at that point. And then they realize they're not even missing it. They're not even hungry in the evening. And they start noticing a lot of positive changes taking place. So what is it that we do once they are eating? Now, this is the synapse here. And you can see that, in fact, the most common class of drugs that's used for depression and anxiety, what do we call them? Yeah, we call them antidepressants, but particularly the form of antidepressants, I heard it. Yeah, SSRIs. So those are called selective serotonin reuptake inhibitors. Do those drugs actually help us to make more serotonin? Do they help us to build up more receptors? No. So why is it that the doctor is saying, well, we're going to put you on this to help your serotonin levels? Well, it's not really helping the serotonin levels, but it is helping short-term the serotonin synapse if you have a shortage of serotonin to begin with. So if you see this slide here, the serotonin is stored in these vesicles. And when an electrical, and of course it has to be made first. And this is another issue that's important to recognize. We don't, if serotonin could be taken up by the brain, one of the most common treatments of depression and anxiety is just come in for your IV serotonin. We can make IV serotonin, we can give it to you right directly in your vein, but that serotonin is not going to cross the blood-brain barrier. It's too large a molecule. The blood-brain barrier is very important. It's what protects your brain cells from neurotoxicity and being destroyed. The oldest cells in your entire body are in your brain. Cells that were in your brain when you are a fetus are still alive and functioning today in your brain. And this is why it has this hard skull. This is why it has this blood-brain barrier that's there to protect us from the larger molecules that are toxins. So serotonin is too large to get in. And so it has to be made in the brain. Even tryptophan is too large to get in. Now, tryptophan is the amino acid we all need to make serotonin, but it has to have a particular carrier. There's a specific carrier that's designed to take tryptophan across the blood-brain barrier, and it actually has to be a carbohydrate-mediated insulin mechanism to get the tryptophan across. So it's quite a process for our brain to manufacture all of these neurotransmitters itself. It can't depend on other areas of the body to do that. And so there's a number of things that can start producing a shortage of serotonin. But instead of necessarily dealing with why the serotonin is short to begin with, or why the receptors are too low, that can be another issue where we don't have enough receptors, the SSRI does come in, and it actually plugs this portion right in here. This is a vacuum cleaner. So when serotonin actually does bind onto this receptor, another electrical transmission occurs. And then when the electrical transmission occurs, this serotonin is released and it's vacuumed back up. Why do you think it's vacuumed back up? What's the purpose of that? The purpose is to preserve it so it can be reused. We just talked about it's quite a process to make for each neuron to make its own serotonin. And so this actually is economizing things, saving energy, saving a lot of issues to have it go through that reuptake channel. But when the reuptake channel is plugged, if there's a shortage of serotonin, you can see that we're going to have more serotonin in that synapse, and we're going to be more likely to have serotonin activity even under a shortage standpoint. And so this is why individuals, and it takes a little while to actually plug those vacuum cleaners. It'll take it at least a week before you start noticing its effect, and it's having some effects in other ways. It's worsening impulsivity. This is why these medicines all have big black box warnings on them. When you worsen impulsivity before you improve depression, what might you increase? You increase the risk of suicide. And this is well known. Now, once the depression improves enough, it can counteract that effect. And so a month later, it doesn't reduce the risk of suicide, but a month later, it's about equal to where it's at. But that first month of taking the drug is a kind of a dangerous time period, particularly when you're giving it to somebody who might already be thinking of suicide. And then over the course of time, though, as you plug those reuptake channels, you're actually going to short the neuron of the very substance that it was already shorted. And so this is why about 9 months later, we need higher doses. This is why we need more medicines, and by the time the individual comes to our program, they're on usually at least 4 different medicines, all different high doses, having all of these significant side effects. And nobody has actually said, why did this individual have a shortage of serotonin to begin with? Where was the defect? What could we have done to actually restore the ability of this neuron to be able to make the serotonin and build up those receptors? So, in regards to the serotonin shortage, we used to think, well, just give them tryptophan. You know, tryptophan is the nutrient that's needed. And yes, tryptophan is vitally important. But notice this statement. Tryptophan is transported into the brain by a transport system that is active toward all the large neutral amino acids. And tryptophan is the least abundant amino acid in protein. There is competition between the various amino acids for the transport system. So after the ingestion of a meal containing protein, the rise in the plasma level of the other large neutral amino acids will prevent the rise in plasma tryptophan from increasing brain tryptophan. The idea common in popular culture that a high protein food such as turkey will raise brain tryptophan and serotonin is what? Unfortunately false. Now, it's not because turkey doesn't have tryptophan. It has it. But it has more of the large neutral amino acids which saturate that carrier. That's very important to get tryptophan across. And so, actually, what's been shown to be healthy is to be getting your tryptophan from plant-based sources where the carbs are there and where you have a better ratio of tryptophan to those large neutral amino acids. So, tryptophan is converted to serotonin. It's also very important for sleep because it's also converted to what? Melatonin. Melatonin is the sleep and rejuvenate nighttime hormone. It's also converted to niacin, B3, which is important for brain health as well. The problem with it is it's the least abundant amino acid in the diet, and there's other factors that can affect it. The conversion of tryptophan to 5-HTP in the brain, which is necessary to make serotonin. There's one more step. It goes tryptophan, 5-HTP, which is 5-hydroxytryptophan, and then it goes to 5-hydroxytryptamine, which is serotonin. And so to even get to that step, it's inhibited by stress. So if you're not coping well with stress, you're actually not going to make as much serotonin. This is something that a lot of our participants, they come to our program realizing that we have done a lot of research on brain chemistry. And they'll say, I'm here to get my brain chemicals fixed. I don't need to have counseling. I don't need to have cognitive behavioral therapy. I'm here just to get my brain chemistry fixed. But it turns out that it will actually help them to fix their brain chemistry if they can think about things in a more rational and helpful way. And that's what cognitive behavioral therapy is about. And cognitive behavioral therapy has been shown to actually improve our ability to make serotonin. And so this is why it's a combined approach. We don't just do nutrition. That can be very helpful. But if people have pathways in their brain that are like highways of automatic negative thoughts, we can fix their brain biochemistry, but those highways are still there. And so we have to actually work with them in a combined approach. And so that's why a comprehensive approach is so superior to just medicating something short term and then having them come back to see whether they need more of that medicine or what side effects, et cetera. But notice it's also inhibited by what? Insulin resistance. What's another term for insulin resistance? Diabetes. Or you can have insulin resistance without diabetes. What is that called? Prediabetes or metabolic syndrome. This is why we measure everyone's hemoglobin A1C that comes through the program. Because if that is part of the reason why they're not making enough serotonin, in fact, some people have recommended we rename diabetes to diapression because they tend to go together because we're not able to make these neurotransmitters as well. So we need to improve insulin resistance. And one of what ways might we do that? That's where exercise comes in. Yes, and so exercise is very important. So it's not just diet, there's also exercise to improve that. And of course, the fasting has already started to improve their insulin resistance. These are the group, the group that we're particularly looking at for fasting that come to our program are those that have issues with insulin resistance. We know they're going to do great as a result of this fast. It's also inhibited by a magnesium deficiency, a B6 deficiency, lack of light. It's light through the eyes, bright enough light to help us turn on our serotonin production in our brain, and of course increasing age. This is why prior to the modern era, depression was only occurring among the elderly. When I grew up in the 1960s, depression was not even a household term. I remember a woman down the street that we didn't see much anymore, and I asked my parents what was going on, and they said, well, she's suffering from a midlife crisis. That was the term for depression back then, because virtually no young person had that. And of course now we've seen a dramatic increase in both the elderly as well as middle age as well as the young people, but there's a very big bubble among our young people now. It's almost uncommon if you don't have depression and anxiety and you're under the age of 25 today because of a lot of the factors that are changing their brain chemistry. So tryptophan, relative to placebo, decreased quarrelsome behaviors, increased agreeable behaviors, and improved mood. And of course that's because its effect on serotonin. Serotonin helps us with those things. It also can improve premenstrual dysphoria and significantly, the PMS. It also improves not only depression, but seasonal affective disorder, insomnia, even obstructive sleep apnea. We're all familiar with CPAP masks, and not as many people familiar with the effects of weight loss and helping sleep apnea. 80% of patients, if they were in their ideal weight, would not need a CPAP mask and not have sleep apnea. But a lot of people are unaware that actually tryptophan, because it improves serotonin levels, actually improves central sleep apnea. And then also withdrawal from drugs. Substance abuse, do you think it's gone up or down in our pandemic? It's gone up considerably. Opioid deaths are skyrocketing as we sit here today. And even nicotine is way on the increase among our younger generation. Most of the young people that come to our program are addicted to nicotine. Does that mean they're smoking? Usually not. They're actually vaping, which is actually even more highly addictive. And it's very tough for them to be able to get off of their nicotine. But they'll be amazed when they come to our program. This was so easy. And I have to caution them, because when they leave, they think, I can pick this up again, and it was so easy, I'll just be able to put it down like I did coming to the program. But no, that's not true. We were changing their brain in very positive ways to make it easy for them. But once they go out, they need to stay on that nicotine-free lifestyle in order to benefit from it long term. So in stress-prone subjects, high-carb, low-protein food prevents a deterioration of mood and performance under uncontrollable laboratory stress conditions. Stress-prone subjects have a higher risk of brain serotonin deficiency, We talked about that connection already. In such subjects, higher natural carbs increase personal control. So that means even emotional regulation, our ability to have self-control, can be improved. Carbohydrates prevent a functional shortage of central serotonin during acute stress due to their potentiating effect, once again, on brain tryptophan. And we also model a plant-based diet in our program. Only one diet has shown improvement in depression in randomized controlled trial, and starting in 2 weeks. There's now a trial where it was 18 weeks that was a semi-plant-based diet that helped. But there's only one randomized controlled trial of any diet that shows benefit across the board in 2 weeks, and that's actually a plant-based diet. And the advantages of it are no arachidonic acid, no cholesterol. High cholesterol is associated with depression and anxiety and more treatment resistant, meaning if you have high cholesterol, you're not going to respond to medicines as well. And of course, it's higher in antioxidants. And the other advantage is better tryptophan and tyrosine brain uptake in the foods that are used. So serotonin regulates executive function, sensory gating, and social behavior. Studies have shown you'll become more social as well, and social activities will be easier for you. But supplementation with omega-3 fatty acids has also been shown to improve cognitive function and behavior and attention deficit hyperactivity disorder, bipolar disorder, even schizophrenia and impulsive behaviors. Serotonin synthesis, release, and function of the brain are modulated by vitamin D as well, and the two marine omega-3 fatty acids, EPA and DHA. Tryptophan hydroxylase 2 is transcriptionally activated by vitamin D, and EPA increases serotonin release from presynaptic neurons by reducing the E2 series prostaglandins. So essentially what that's saying is the E2 series prostaglandins, which are the pro-inflammatory, we get rid of the arachidonic acid, we don't have the pro-inflammatory part of things, and then when we get omega-3, that's very anti-inflammatory, and that'll help us to be much more able to release serotonin from the neuron. DHA influences serotonin receptor action by increasing cell membrane fluidity in the postsynaptic neuron. And so this is helping the receptor aspect. So we're actually getting a dual benefit with EPA on one side of things, helping us to release serotonin better, and DHA helping us with the receptor types. And of course, there's 3 types of omega-3, alpha-linolenic acid in land plants. And many people think, well, that's not EPA and DHA, but it actually can be converted. And it requires actually several things to make this conversion. You have to have B3, which is niacin. You have to have vitamin B6, which is pyridoxine or 5-pyridoxal phosphate. We have to have enough magnesium, zinc, and vitamin C. And so once again, we have this comprehensive approach. And it's also been shown to upregulate BDNF even further, the omega-3. And so omega-3 from marine sources itself, the fish sources, have risks. What is the risks of the fish sources of omega-3? It's mercury and toxins. And there have been some recent studies. In fact, we did one on our, at this time I think we had 6,000 people that had gone through our outpatient program. We did an analysis of their fish intake, and actually fish intake increased depression and anxiety, even though it can help with the omega-3 because the toxins were outweighing the benefits. And others have produced studies showing, or looked at data showing exactly the same thing. Back in the 1980s, we were telling people to eat more fish, and that seemed to be beneficial. Those earlier studies were beneficial, but now mercury has gotten in even to the Aleutian waters and the Canadian lakes, and that mercury is actually outweighing the benefits that are there. And so land sources or even algae sources may be superior. But these are the land sources of omega-3. Oatmeal, whole wheat if you're eating white bread, you're not getting your omega-3. Spinach is a good source. a different type of broccoli. Rapini broccoli is high in omega-3. Avocados, one avocado will have 223 milligrams, navy beans 322. Kale is actually higher than spinach in omega-3. And edamame is even higher yet. Edamame is your green soybeans. Your mature soybeans are going to be high in omega-6. The green soybeans high in omega-3. Red bell peppers are excellent sources. Tofu is an excellent source, and hemp even more per ounce. Walnuts a little bit higher than hemp, and then we get to chia, which is loaded with omega-3, and the highest source known in concentration, even higher than any fish out there, is actually flaxseed per ounce. But we want to get this with vitamin C to convert it over into the long-chain omega-3s. So this is why the fruit aspect of things can be good. Papayas, oranges, Brussels sprouts are loaded with vitamin C. Strawberries even more. Broccoli is a good source, and kiwi is a very high source of vitamin C. And then we have things like black currants that are high, pokeberry shoots, excellent. Red bell pepper come out high on both sides of this equation. Sweet yellow peppers even higher, and pomelo, which is a starch type of root, 371 milligrams. Guavas, 377, and then way up the line are the acerola cherries. And so vitamin C combined in getting vitamin C, enough vitamin C plus these other nutrients will help us significantly with brain health. A couple of other things I'd like to mention. Zinc. Zinc has been shown to be effective as an antidepressant alone, or in addition to SSRI and TCA medication. TCA is the tricyclic antidepressants. And these antidepressants, in fact, some of the newer ones are actually putting zinc with them because they know it will actually augment the effects of their antidepressant medicine. 2 weeks of zinc supplementation actually increases the serotonin receptors, both the HT1 and the HT2 serotonin receptors, so you're going to get more serotonin activity. And it's also been shown to improve ADHD. Of course, many people have been taking zinc because of the pandemic and how it can help the immune system. But these are foods that have zinc. Legumes tend to be your higher source per cup. Tofu is an excellent source. Adzuki beans and baked beans even higher than tofu. And then nuts also tend to be pretty high in it. Sunflower seeds will be high in it. Cashews, pine nuts, pumpkin seeds, even oats are an excellent source of zinc. And hemp seeds actually come out high on both the omega-3 and the zinc. Magnesium, we mentioned it earlier, increases brain serotonin levels, improves depression and anxiety, even alone in a nice randomized controlled trial starting 2 weeks from magnesium supplementation. This was 500 milligrams of magnesium 4 times daily. That's only producing 248 milligrams of elemental magnesium per day, but it's been shown to help with methylation, and it can augment other neurotransmitters, including GABA-aminobutyric acid, which is a calming neurotransmitter. Magnesium is going to be present in vegetables, particularly these vegetables that are listed. It's also going to tend to be high in seeds and nuts, particularly again, pumpkin seeds and hemp seeds. But spinach is actually an excellent source of magnesium, as is Swiss chard and lima beans. Flaxseed also high on the list. And so we're going to be giving individuals in our program foods that have zinc, foods that have magnesium, foods that have the right amount of tryptophan. And even the legumes are a pretty good source of tryptophan. You can see edamame, 148. We serve edamame at our lunchtime meal every meal, actually, in the salad section. And then even the grains can be high in it. You can see oats, an excellent source of magnesium, and buckwheat is even higher than oats. And so I know I started late, but I'm also going late, so...
No, you actually have 5 more minutes.
Yeah, I have 5 more minutes? Okay. I was wondering about the time. I don't want to be disrespectful there. But there may be some other supplemental aspects that can help in certain cases. Selexon is an herbal preparation that actually has been purified from lavender oil. And it's been shown to have significant anti-anxiety relieving properties without sedation. There's no addiction, and there's no frontal lobe suppression. The most commonly used drugs for anxiety outside of the SSRIs are going to be your benzos. And your benzos are going to suppress your frontal lobe of your brain. They are highly addictive, meaning that they're only very helpful for about 2 weeks. And then after a month, if you try to get off of it, you're going to have tenfold worsening, because after 30 days of being on a benzo, your brain shuts down its GABA production, its ability to make GABA aminobutyric acid, which is that calming neurotransmitter. And of course, these medicines also cause sedation. And
Shuts down what?
it shuts down our ability to produce GABA. Yeah.
GABA?
GABA, yeah. So GABA, we have a manufacturing plant for GABA as well. Since these benzos fill the GABA receptors, the brain's saying, hey, these receptors are getting filled. I don't need to make this GABA anymore. And so it actually shuts down that manufacturing plant. And this is why people get hooked. This is the element where all of a sudden they think their anxiety is just as bad. I don't think this drug's helping me. They try to get off it, and it's now tenfold worse. And of course, Selexon actually has been shown to be helpful in getting people off of this. In fact, Selexon was tried against lorazepam as far as its anxiety relieving properties, and is actually equal to lorazepam, but without any of those adverse effects. And it's now found to be also an antidepressant. It's been shown to increase serotonin release and extracellular brain serotonin levels. This is one of the things that's kind of also my pet peeve. We as Americans, or maybe humanity in general, we have this tendency that when we're feeling bad, we go to things that will help us short term but have significant risks. This is the issue with the increase in marijuana production and marijuana consumption. Marijuana significantly increases the risk of psychosis. There is no argument about this whatsoever. Just look up marijuana-induced psychosis. It's 10 to 12 times increased risk. And once you get psychosis from it, I mean, this is a terrible situation that results. Yes, it can calm you because it can fill those cannabinoid receptors. But why is it that we're searching for things that have benefits and risks? By the way, marijuana also suppresses the frontal lobe, and so you're not going to be as good on the executive aspect of things and planning, and also it's going to adversely affect relationships, and it has this addictive potential as well. And instead, we're totally ignoring things like Selexon that have only been shown to have benefits and no risks. Why is it that we ignore things that only have benefits and no risks? And we're continuing to try to play this tightrope with things that have benefits and risks. And so we actually had, even though I'm from Northern California, which is very famous for its marijuana production and also consumption, interestingly, in our town, in our entire county of Placer County, there's no marijuana dispensaries allowed. And of course, they've caught up with all the issues. You have increased police force that's needed, increased security, all sorts of things. And one town close to us decided that they wanted to start a marijuana dispensary. And some of us at Weimar University that take care of individuals that are on marijuana, we showed up for the meeting and also showed them the data on this. But we asked the store owners who were saying they were going to increase their revenue by $4 million by doing this. Why not hold something? Why not sell something that only has benefits? Do you even have this available? No, we never heard of that. I don't even know that it's available. It actually is available. It's over the counter, and it's available. Well, maybe I better stop at that point. We could go on further, but certainly, hopefully you've had an introduction to the fact that what we put into our body and when we put it in can be vitally important for our mental health now and in the future. And it can make a difference that often surpasses the effects of the pharmaceuticals while avoiding a lot of those side effects. Thank you very much.
Thank you so much. Thank you so much. We're going to hold questions off till lunchtime, if that's okay with everybody. If you have questions for Dr. Nedley, please jot them down, and we'll make sure that we get those questions answered. Additionally, it's 11:15. We're going to go directly to our next speaker, and then we will break for lunch. So our next program is Dr. Wayne Dysinger. And our topic today is lifestyle medicine practice, what it is, and why you should consider incorporating it into your healthy lifestyle. So Dr. Dysinger is a lifestyle, preventative, and family medicine physician who currently serves as a physician, chair and founder of Lifestyle Medical, a new model group of primary care clinics built around lifestyle medicine principles. He is also the co-founder of the Lifestyle Medicine Network, a collaboration of primary care practices throughout the United States that all have a lifestyle medicine foundation. Dr. Dysinger is the chair of both the American Board of Lifestyle Medicine and the International Board of Lifestyle Medicine. Very cool. He is an active faculty at Loma Linda University and consults, teaches, and participates in research on lifestyle medicine issues around the world. So welcome. We're experiencing technical difficulties. Please stand by. In my spare time, I'm a comic.
Okay, so I want to start off by saying it's a privilege to follow Dr. Nedley. Did he leave already? So Dr. Nedley and I were actually classmates. We actually went to medical school, graduated the same year in 1986, so that's a long time ago, from Loma Linda University. But I want to say this with him here, but I don't see him. But I'll tell you guys two things. One is he was the smart guy in our class. So he was always the one that was sitting on the front row and, and almost, so he's not here, so almost like the nerd, right, in the class. But the interesting thing is he's also the one that got the girl, right? So he met this cute European, and I remember when he started dating her, sometimes she would even come to class, and it was fun. Those are good memories. But anyways, it's fun to be here with you all and to talk about the practice of lifestyle medicine. I want to just spend a little bit of time talking about the lifestyle medicine philosophy. And I know everyone here probably knows this, so forgive me for going over a couple things you know, but I just want you to see our angle a little bit, because that actually matters in some of the other things that we're talking about. And then I'm going to talk about the practice that I have. So I spent most of my career in academia, so I was teaching medical students and residents and that type of thing. But as I was getting into this lifestyle medicine, it felt like we needed an economic model for lifestyle medicine, because it could be a good idea, and it could be scientifically good, but if it doesn't work in the real life, it's not going to really go anywhere. So we developed that. We started about 7 years ago, and we've developed something that works well economically. So I'm going to share that with you. And then I'm going to share a few stories from some of my patients to finish up with. So this is my core lifestyle medicine philosophy slide. I actually show this to most of my new patients as they come in. But what it does is it highlights the fact that when I was in medical school, when Dr. Nedley and I were going to medical school together, we spent our time learning the top parts of this triangle. So learning how to prescribe medications, learning how to do procedures. That's what medical school is about. That's what our residency training was about. And in fact, that's what the whole healthcare system is about, right? I mean, We're here in Rochester, the famous home of Mayo Clinic. What is Mayo good at doing? These two things. Prescribing medications, diagnosing, prescribing medications, treatments, all these procedure things that are high risk and high cost and foreign and invasive. If we look at the healthcare problems in the United States, and not just in the United States, actually really the whole world around, what are the healthcare problems that we have? I mean, the term we use is chronic disease, right? So chronic disease, and it can be depression, it can be diabetes, it can be arthritic kinds of things. Anything that you have in your system for more than a couple weeks is considered a chronic disease. And the data says that 80% of our healthcare dollars, 80% of our healthcare interactions, they're all around chronic disease right now here in the US. And if you look at chronic disease, what drives chronic disease? It's lifestyle. So 80 to 85% of the causes of chronic disease are lifestyle. So that if we actually had a perfect lifestyle, literally 80 to 85% of those chronic diseases would disappear. They'd go away. Now, unfortunately, nobody has a perfect lifestyle. I wish I could say I did, but I don't. I don't have a perfect lifestyle. I don't know if anybody here claims a perfect lifestyle. If you do, I'd like to meet you. But really, we can't do that for a variety of reasons. We're human. We're fallible. But we can get closer and closer towards that, especially if we create a culture around that. And I know that's part of the goal for this weekend, especially what we're going to be talking about tonight, is creating a culture of a healthy lifestyle here in Rochester, Minnesota. But lifestyle medicine, of course, is saying if 85% of what we're doing is caused by this, as a physician, we ought to start with that, right? So we ought to start with these nourishment, movement, resilience, and connectedness. And then if that doesn't work, we can go to some of the supplements like Dr. Nedley was talking about. And then there's still place for this. So I still prescribe medications in my practice all the time. So that's needed, and we want to have that as part of what we do. But let's start with this. Let's make it the biggest thing, the most important thing, because it's preventive and it can actually even reverse some chronic diseases. So another philosophical thing about lifestyle medicine is this concept of it being whole health. So again, when I was in medical school and residency, a lot of what I was taught is that we need to understand what's broken in our bodies. We need to understand what's not working right, the thing that's broken or that needs to be fixed. And then our job as a healthcare provider is to go fix that. And then once we fix that broken thing, then the person's going to be better. They're going to move on with their life and they're going to be better. So that's one sort of reductionistic or approach to thinking about healthcare problems. What lifestyle medicine does is it says, we don't really think the core thing is a broken human being. We think the core thing is a human being who's out of balance. Someone who's gotten off a little bit on maybe how they eat or maybe how they manage their stress, or some part of their body has gotten out of balance. And so what our primary job is to bring that person back into balance, to help them maintain a better exercise program, help them get better sleep. Whatever it is that's out of balance, our job is to sort of help them bring them back into balance. And then once they're back into balance, guess what their body can do? Can heal itself. So they're not a bunch of broken pieces. They're somebody that's out of balance. We bring them back into balance, and then they can go forward. Not to say that things don't get broken. We have accidents, we have infections, we have other things that we do need to fix. But the core thing, and we learned this with COVID, if you're in balance, you're much less likely to get that infectious disease. You're also much less likely to have that accident. So bringing ourselves back into balance is incredibly important. So I also wanted to show this slide. I've never shown this slide in a talk before, but I'm just curious. Anybody here heard of polyvagal theory? So we have a couple people. This is something that I recently became connected to or recently understood. It's actually been around for 10 or 15 years, so it's not a new theory, but it's growing in significance. And this is a very busy slide, and I'm not going to try to go through the whole slide, but I love the headline. Actually, Stephen Porges is the person that really developed this polyvagal theory, and the easy to read book is called The Polyvagal Theory: The Transformative Power of Feeling Safe. So it's really talking about how feeling safe is healing. If we feel safe, we can heal. If we don't feel safe, it's hard for us to heal. And this is not just a theory. He has research that shows how our vagus nerve, so this is a picture of the vagus nerve. So it starts up obviously in the brain, but then it goes throughout all of it goes through our heart and our circulatory system. This is all in the gut, the GI system. So this vagus nerve is affecting our whole body, and it's affecting it not just by messages going out to it, but by picking up messages and taking those messages back to our brain. And again, without going into all the detail of this, this vagus nerve helps us figure out if our body's safe or if it's not safe. And it does that by looking at how you look at me. So as I'm looking at you, if I see someone that has sort of a threatening appearance in their face, I'm going to feel less safe, and my vagus nerve is going to kick into different ways. So we can talk about that more later if there's questions, but the point that I'm trying to make is that we have biochemical, biophysiologic mechanisms that are mapped out that help us in this idea of feeling safe and in this idea of creating balance in our world. Okay, I just want to briefly talk about what we talk about in our practice, the 4 pillars of lifestyle medicine. So they were back in this slide: nourishment, movement, resilience, and connectedness. Just in a little more detail, nourishment is anything that comes into our body, so it's how we take energy into our body. So it's obviously food, it's any liquids that we take in, it's other things that we might expose ourselves to as well, including some harmful things like certain drugs, tobacco, those kinds of things, and toxic substances as well. So nourishment is energy coming into our body. Movement is how we use our energy. So it's obviously classic exercise things, and it's all the components of exercise. It's also the environment that we exercise in. So we believe in the power of fresh air and sunshine and those kinds of things. It's recognizing that if we sit all day, that's also harmful for our body. Even if we exercise, have a good exercise session every morning, and then we go and sit all day, that's an issue. So if you want to get up and walk around while I'm talking, I'm fine with that. And then resilience. Resilience has 3 components. One is sleep. So we know that we need 7 or 8 hours of sleep each night, and people that get that regularly do better health-wise. Resilience is also stress management, how we deal with the things that are threatening the energy in our body. And it's giving ourselves these moments of rest and renewal, like Dr. Nedley talked about, and Dr. Lai talked about as well. So we have to give this on a regular basis. And then the final thing that we talk about is the idea of connectedness. And connectedness includes what we talk about as horizontal connectedness. So that's my social networks, my friends and my family, and the groups that we interact with. But we also talk about vertical connectedness, which is this idea of purpose and meaning. What is the why? Dr. Lai talked about this earlier. And we need to understand that as a lifestyle medicine practitioner. I need to understand my patient's purpose and meaning. If I don't, I have a hard time bringing them back into balance or helping them achieve balance. Okay, a little bit more about the practice. What do we actually do in a lifestyle medicine practice? What makes a lifestyle medicine doctor different from a typical primary care doctor or other doctor that you might see? So we actually have mapped this out at some level. We have 10 different things that we think make a lifestyle medicine practice different from a typical practice. But in categories, we assess differently, we treat differently, we have a variety of programs, we have some other things that we do as far as staying connected to our patients, and then there's a different knowledge base too. There's some certification and those types of things that happen. So this is a slide of a family, and as you look at that slide, what do you see? You see different generations, right? You see some older people, some younger people. You see different ethnicities. You see different emotions. There's a lot of happier or excited emotions here, but you know also in that family there's sadness, there's fear, there's anger. There's a variety of emotions. But it's this very full, rich, sort of deep picture of who a human person is. As physicians, we tend to look at people by things like heart rates and blood pressures and sodium levels and hemoglobin A1C levels. And we tend to break people down into a variety of different measurements. And then, the classic thing is in residency, you're doing rounds on the hospital, and we're going to talk about the gallbladder in the next room. We're going to talk about, the meningitis in the next room. So instead of it being a person, it's a diagnosis. Well, this is not really how any doctor, I think, went into medicine wanting to practice. They didn't want people to be a bunch of numbers, a bunch of squiggly lines. They really wanted people to be this rich family, these sets of emotions, these connections, these different backgrounds, all these stories that make us who we are. Part of what lifestyle medicine is doing is trying to reclaim this and not ignore this. So this still needs to be there. All those measurements matter. They make a difference. There's a reason why we've tracked those and we've developed those and why those are important. But the main picture needs to be this. This is the holistic picture that doesn't break us down into these reductionistic things that may or may not be broken. So one of the things that we do, and that a good lifestyle medicine practice does, is it has what we call lifestyle medicine vital signs. So remember those 4 areas that we talked about? Nourishment, movement, resilience, and connectedness. Well, we measure those, and we measure those every single visit for every single patient. So when a patient comes in, we actually give them this piece of paper. And they will fill it out. And in the first time or two, we have to sort of explain it to them and tell them. But after a while, when they walk in, they just grab the piece of paper, they fill it out. And in our virtual visits, we also will ask them, how do you fit on this? Because that matters. What you measure is what you manage. So if, as a doctor, if I measure these things, then I'm going to manage them. So we do that for every single visit, for every single patient. We also have a more comprehensive thing. So if someone comes in with a low number in movement, we ask additional questions. So there's more that we learn about their movement. So we have ways of drilling down and tracking this in our electronic medical record. So if you go to one of my patients' charts, I can tell you, for instance, around nourishment, I can tell you, I'm not perfect at this, so not every single patient every single time, but at some level I can tell you, right now, this patient is approaching nutrition this way. A year and a half ago, they were approaching nutrition this way. 5 years ago, they were approaching nutrition this way. So I can sort of track that and manage that because it matters. These things matter as far as how we're building. So if you have a lifestyle medicine practitioner, you're going to be spending time explaining to them these things. And I just say this. I'm sure some of you are healthcare professionals here. As a healthcare professional, if someone says, what is your social history? What does that mean to you as a healthcare professional? Social history. So if you're married. So I'll say this. When I was in medical school, social history was basically, do you smoke or do you use alcohol? That was what social history was. Is that ridiculous or what? I mean, since when is social history whether you smoke or whether you drink? In our practice, social history is who do you live with? What is your marriage status? Do you have kids or not? What's the status of your kids? Even who's your friend connection? All of those things matter. So social history. So as we look at these different things and break them down, those are incredibly important as far as bringing that balance back into life. So I'm just doing this briefly. So that was a brief overview of how we assess differently. This is going to be a brief overview of how we treat differently. So in our practice, we have what we call our lifestyle medical clinical protocols. So we have them broken down into different categories. We have a way of going to those and putting them in. And then more importantly, we have templates that we can use in our practice. So if you come to me with inflammation, so let's say your shoulder's sore and has been sore for the last 6 weeks, and you've done certain things at your house to try to improve that. It's not gotten better. You show up with me. You're complaining of a sore shoulder. Well, I will most likely give you not a prescription for naproxen. I'll most likely give you a prescription for an anti-inflammatory diet. So I will prescribe specific foods. I'll even name the foods out. I'll prescribe a specific amount. I'll tell you how much I want you to take those. So 1 cup daily of cruciferous vegetables and the details of an anti-inflammatory diet. And why do I do this? Well, I do this because these are the foods that are highest in antioxidants. Antioxidants are incredibly important as far as decreasing inflammation in your body. And I want to give your body the best chance of decreasing inflammation on its own. That's one of your body's mission is decreasing inflammation. And so if I help your body decrease inflammation, it's very likely your body on its own can improve that shoulder soreness. Now, sometimes that doesn't work. And you remember the triangle I showed you. If that doesn't work, what do? We go up to supplements. So we can add supplements like turmeric or ginger that will also help decrease inflammation. Now, sometimes that doesn't work as well. So if you remember the triangle, where do we go next? Medication. So I'll sometimes prescribe naproxen or piroxicam or some other medication that I like for inflammation as well. And then obviously there's mechanical things that we have to think about. There's sometimes physical therapy comes in. There's a variety of different things that we can also do. We may need to do some diagnostic things, but why not start here? There's no risk, and this obviously this diet's going to help not just with your sore shoulder. It's going to help with your whole body. So we actually start here, and guess what? It works a lot of the time. So why not go with this low risk, as Dr. Nedley was saying? Go with this thing that adds amazing benefits and has no risk and very little cost as well. So that's another thing that we do. We prescribe differently. We treat differently. A lifestyle medicine doctor also is going to have other tools in their armamentarium. So one of the things that we do in our practice is we have a lot of groups. And we have different kinds of groups. Some of our groups are meant primarily just to give you information. So this symposium, it's really coming out of Dr. Lai's practice. The main reason why this is happening is to share information. That's the main reason here. So we have groups that do that. We have a meditation group. We have a series of nutritional education groups. We have cooking classes. We have a variety of things that give people knowledge and skills and sort of educational kinds of groups. We also have what we call clinical groups. These are groups where people come together and deal with a particular clinical issue together. Sometimes those are specific disease related. Sometimes they're what we call drop-in group medical appointments. So we just need more space. We need more availability. So different people will come in a group and will sort of deal with their back pain or their cough or even their high blood sugar all together in what we call a drop-in group medical appointment. And then the group that I actually enjoy the most is our support groups. Those are the groups that help our patients stay with their lifestyle choices. So all of you make lifestyle choices every day. all of you, I'm sure the city of Rochester, Minnesota has reasonably good support around the lifestyle choices. But as a general rule, our society makes lifestyle choices harder, not easier. As a general rule, our society is obesogenic and diabetogenic. We have a lot of high calorie, very taste attractive foods that call to us, right? We have a lot of ways where where exercise becomes a secondary thing. So it's not a natural thing that we do in our day-to-day basis. So we need support groups that help change our culture, that help change how we go through our life on a daily basis. So we have these support groups that people will come to, some weekly, some less frequently, but it gives people a place of accountability, a place of checking in, a place of reminding themselves that if I spend time every week looking at how I approach my lifestyle, I'm more likely to have a good lifestyle than if I just naturally follow what society is putting in front of me. Another thing that's important for a lifestyle medicine practice is to have some connection to a more aggressive lifestyle change program. So tell me, Dr. Nedley, I think that's Weimar. Is that Weimar? I believe it is. So that's actually where Dr. Nedley's from. So he has a very aggressive approach. You know, we call it it's a residential program where you can go to Weimar and you can stay there for I don't know all the lengths of Dr. Nedley's programs, but and we obviously don't have that in our practice, but we still have community-based things. I saw somewhere over here, yeah, there's a CHIP program over there. So CHIP is something you can do in your community. We've done in our practice, it's a more aggressive lifestyle change program. But it's the idea that some people need to be more aggressive as far as their lifestyle. Just like we need an ICU in the hospital, we need an intensive lifestyle change program. So a good lifestyle medicine practice is going to have good connections to that as well. Another thing that we have in our practice, and I'm not going to go into this a lot of detail, but every single patient in our practice has what we call our health connection score. And their health connection score, you can see someone who's super healthy, we want to connect with them once a year. Dr. Lai talked about how he has different rhythmicities as far as how often he connects with people around their foot. We do that around their sort of whole body. People who are really sick or in the hospital, we're trying to connect with them every single day. So you don't have the same score all the time. Your score will go up and down, and it's based on objective things. So some of it's based on what your hemoglobin A1C is or what your blood pressure numbers are. It's based on certain utilization things. So if you've been to the emergency room, that's going to increase your health connection score. But it's also based on subjective things. It's based on what I know of my patient, what I know of their needs, what I know of those other components, you know, their social connections and all those other things. And we have a way that we track this. So every day, our team will get together and we'll talk about the people that have 10s, and then twice a week we'll talk about the people that have 9s and going down. So we have ways that we track this, and that matters because not only are you thinking about your health, your doctor's thinking about your health, even if you're not thinking about your health. So it's a way that we proactively interact with our patients. So the final thing in that list of 10 things that make a lifestyle medicine practice different was lifestyle medicine certification. So I just want to say that there's more and more training in lifestyle medicine. So these are lifestyle medicine residencies around the country. There's 49 institutions. In those institutions, there's 82 different residency programs. And currently about 2,500 medical residents. And this is family medicine residents, some of them internal medicine, some of them preventive medicine, a variety of different residencies. That's currently, so I'm actually the chair of the board of lifestyle medicine that certifies, and in our board meeting, go ahead.
Are there any in Minnesota?
There are none in Minnesota right now. right now. But in our board meeting just 3 days ago, the lady that's coordinating this says for next year there's going to be, I think, 39. I think she said 39 more sites, and 40 to 50 more programs. So we're going to be up to around 120 or 130 programs around the country. And I actually don't know if any of those are in Minnesota either.
It's kind of hard to see.
But there should be, yeah. Right now there's none in Minnesota. There's a lot in Pennsylvania. The University of Pittsburgh Medical Center has multiple residencies that are doing it. There's a lot in California, Texas, Florida, a bunch in Washington State. There's a big interest in lifestyle medicine there. But plenty of places that still can add it in. But the point is, guess how many of these were in existence 4 years ago? None. Zero. So it's growing really, really rapidly. So also growing rapidly is certification in lifestyle medicine. So this is actually a world map. Certification started in just 2017. So we've only had 5 certifying exams so far. And right now, there's over 3,000 physicians around the world that are certified. About 2/3 of those are in the U.S., so most of them are in the U.S. But you can see we're all around the world. We give this lifestyle medicine exam in 7 different languages. You can see it's physicians from 72 different countries have become certified in lifestyle medicine. So it's a rapidly growing thing. Again, this started just in 2017. So there's a lot of interest in this. And the fact that I'm up here talking about my practice in Southern California, Dr. Lai has a lifestyle medicine practice. Obviously, he's a podiatrist, but he's had physicians and other people in his practice that can help you in your primary care needs, as well as obviously he can help you in your podiatric needs. So, how do you find a lifestyle medicine physician? How do you find a practice near you? The American College of Lifestyle Medicine, that's the professional organization for lifestyle medicine physicians. This is a rapidly growing organization. Again, 4 years ago, 5 years ago, it probably had a few hundred members. Guess how many members it has now? It has over 7,000 members in the American College of Lifestyle Medicine. Most of those are physicians. And you can go to their website. Their website is lifestylemedicine.org. This is just a screenshot. I didn't figure it made sense to try to show this to you. But if you go to resources and then go here to find a lifestyle medicine expert and hit that, there's actually a search thing. So you can put in your zip code and you can find the lifestyle medicine physicians that are within 20 miles of you or that type of thing. So it's a very nice resource. And I should have, but I did not put in the local zip code to see how many lifestyle medicine physicians are here. But I can almost guarantee you, since there's 2,000 physicians in the U.S., I can almost guarantee you there's several right here in, do you know how many physicians here in?
2 and him. And then Dr. Misik is 1. Yeah, 2 cities. But then, yeah, I think there's about 5.
So there's several around here. Part of the challenge and part of what I'm doing, part of the reason why I'm doing what I'm doing is if you wanted to practice this different way, this lifestyle medicine way, it was hard because it was not clear how you would do it economically. So that's actually what I'm going to talk about next. But just before I do that, to summarize, we talked about how we assess differently. We talked about how we treat differently. We talked about how we have different programs, different other resources for our patients. We talked just briefly about this connection system that we have, and then we talked about certification. There's also a whole set of things that we do as far as practicing differently from a sort of administrative or economic perspective. And I'm not going to go into all of these in detail, but I just want to show you a few pictures. So in our practice, we have 3 levels of people that work in our practice. So we have the providers, Those are the doctors and the physician's assistants, the nurse practitioners, and that type of person. So we have those. We're not a large practice. We have 4 providers in our practice. Then we have the advisors, which I'm going to come back to. And then we have these things that we call these people, that we call medical assistant coach navigators. So those are our medical assistants. But then we give them a little extra training in coaching, and they become we call them the patient navigator for our practice. So if you come to our practice, not only will you have a primary care physician that you're assigned to, you'll also have a MACN that you're assigned to. So every single patient in our practice knows their primary care physician's name and knows I don't know if they all know their MACN's name, but they could know their MACN's name, because we can tell them in their chart who is their MACN and who is their physician. And that MACN not only will help them check in when they come and see the doctor, but will also help them if they're trying to get their appointment with the orthopedic surgeon. They'll help them arrange that. Or if they're trying to get their appointment with the MRI, or whatever it is that they need as far as navigating the healthcare system. And they'll also help them, so if they make a particular health goal. So say they want to do a simple thing. They want to eat Brazil nuts every single day. The MACN can call them at the end of a week and say, so how did it go this week as far as eating Brazil nuts every single day? So we have the providers, we have the MACNs, but then we also have these advisors. And these are people, so these are actually our real advisors. So this is Kelsey, she's our dietitian. This is Alma, she's our social worker. And this is Nan. We have several certified health coaches, but Nan the MACNs have sort of a superficial training in coaching, but she's certified. She has she's actually written books. She's an amazing person. So these are the people that we have in our practice that we make available, and these are the people that run most of our groups. So the groups are generally not run by physicians; they're run by some of these people. They'll do one-on-one counseling with our patients, and they'll do a variety of things to try to help them reach those lifestyle needs. So that's staffing. This is an actual picture of one of our physician rooms. So how many of you, when you go to your doctor, sit in a room like this? Maybe if they're a psychiatrist, right? Maybe you might sit in a room like this. We actually think that lifestyle medicine is closer to psychiatry than it is to a lot of other specialties, because part of what we're trying to do is help them in health behavior change. And health behavior change is not an easy thing. But we wanted to create an atmosphere that would make it more comfortable for them to talk about their challenges, as well as allow us to give them this safe place we talked about in the polyvagal theory, this place where they can feel safe to share who they are and what they're trying to do, and we can help them along that journey. So it's comfortable, it's soothing, and it's friendly. So most of our rooms are in this nature, right? We're still medical doctors, so we do have one room that has a classic exam table and all those kind of things, because we still sometimes have to do procedures and other things. But most of our interactions are done in rooms like this. This is just a little bit about our schedule. So we have longer visits. If we really want to get to know our patients, really want to help them with their lifestyle changes, we have to have time to do that. So we specifically have longer visits, and I won't explain the details of all of these abbreviations, but suffice it to say, we try to make ourselves available all the time with patients. We do a lot of emails with patients. We do a lot of phone calls with patients. So this classic thing that, it used to be that if you wanted to interact with your doctor, you would call their office, you would schedule an appointment, you would go there, and you would sit down in front of them, and you'd interact that way. That's changing, and we know that's changing. We were forced to change that in COVID, but it was changing even before COVID, and it's going to continue changing. So the interacting with your doctor may be, in the future, a lot of interactions versus in a social media setting. So it may be that you're interacting with your doctor as a group in a social media setting. It may be that you're interacting with your doctor maybe once a year in person, but all your other visits are going to be virtual visits. So there's a variety of things we do. And so we've set up our schedules so that we can do these kinds of interactions with our patients. But we're also very available. We have 24/7 phone calls. We have, so they're not stuck going to the emergency room or calling other people. If they have a healthcare need, we're there for them. We consider them family, and we want to be available to them like family. So this is one of the biggest pieces. If you're trying to help someone on that lifestyle medicine journey, it's hard to do it in an episodic care manner. So the lifestyle medicine provider really needs to be able to step back, look at the big picture, and then help them in a continuous and ongoing manner. But guess how healthcare reimbursement has been historically? It's been episodic, right? So as a doctor, how did I get paid? I got paid if you showed up in my office. That's how I got paid. I didn't get paid in any other way, only if you showed up in my office. So at some level, I was incentivized to have you come back again and again. I was incentivized actually to have you there for a short period of time, because I got paid the same amount whether I spent 10 minutes with you or 15 minutes with you. And so it was just these wrong incentives. And that's still the way most of healthcare is incentivized, but more and more there is this thing that we call capitated reimbursement. Another term that's being used sort of by the corporates is value-based care. But the idea behind this is that I get paid as a doctor on a monthly basis for how I take care of my patients. So if you're my patient, I will get a certain amount every single month, and then it's my job to take care of you. So the biggest payer for this capitated or value-based approach to reimbursement is actually Medicare. So I'm looking around the room. I'm guessing some of you are on Medicare. How many of you are on Medicare Advantage? So several of you are on Medicare Advantage. Medicare Advantage is the capitated or value-based approach to reimbursement that Medicare has. And Medicare Advantage, it matters or it varies from part of the country to part of the country. So I don't know how your primary care doctors are reimbursed from Medicare Advantage. But in Southern California, the way we're reimbursed is through a monthly amount that we get. As a primary care doctor, I get a monthly amount. And it's usually around $100, $120 a month. It varies from contract to contract. So our practice, every single patient in our practice is a member. They're part of our family, and they're a member. And there's ways they can get into membership. One way is through Medicare, where there's no additional fee for them. They're just automatically, because we have this capitated thing that Medicare pays for us. We also have a way, so if you have a very high deductible insurance, or maybe you don't have good health insurance, we have a way that you can be part of our practice and get all our services. You get all the coaches, all the advisors, you get all our programs and everything for this price. Or if you have insurance, because we do a lot of things that other practices don't do, and this is becoming a more common thing, we'll charge a little more. So if I have an HMO insurance, so if a patient has an HMO insurance, guess how much I get paid as a primary care doctor to take care of that patient every single month? In Southern California, I get about $15. So that means over the course of a year, I'm expected, for about $180, I'm expected to provide all the primary care services for that patient. Do you think I can do all the things that I do for $180? Not even close. So we charge this amount additionally, so basically doubles what we get for that patient. And it's hard to even provide everything that we do for this amount, but we can generally do it on average. So that's what we do for people who have insurance, who are under 65. And then if you're over 65, you have this. Now, I asked how many people have Medicare Advantage. How many people have regular Medicare, what's also called Medicare B? So a lot of you have that. There's a new program now where I, as a primary care provider, can get paid in a capitated way or a value-based way for regular Medicare as well. So we've signed up for that program. Dr. Lai, I think, is going to be signing up for that program for his primary care patients for 2023. But what it does, again, is it sets up the doctor to be thinking of you in this big picture lifestyle medicine way, because they're getting reimbursed not to keep you sick, but to keep you healthy. So in these capitated reimbursement systems, if a patient is healthier and doesn't require as many services, my reimbursement actually goes higher. If they're sick and if they're in the hospital all the time, my reimbursement actually goes lower. So I'm very incentivized to keep them out of the hospital and do everything I can to keep them healthy. So that's sort of the financial side of piece of things.
How does that work? If they're sick and in the hospital, you get reimbursed less? I don't understand.
So what Medicare does is, well, and again, this varies from contract to contract, and it's complicated. But as a general rule, what Medicare does is there's a certain amount that I get on a monthly basis, but then at the end of the year, Medicare will say, these are all the expenses for this particular patient for this particular year. And those expenses, the biggest expense by far is hospitalization, but it's also ER visits, it's also any number of other things that go on with a patient that require expenses. And if that patient has cost more than we expected them to cost, then I will actually get less money. If it costs less, then I'll actually get more money. So if I can help the overall healthcare system save money, then I actually am incentivized to do that. So it's a true up that happens at the end of each year.
Okay, so what I'm understanding is there's an amount of money per patient, but if they use up that money in the hospital, you get less.
That's a reasonable summary. It's way more complicated, but that's a reasonable summary of it. Yes.
Yeah, okay, thank you.
Yeah. So we're wrapping up here, but I want to tell you a few stories. But I also just want to point out that lifestyle medicine is evidence-based. So, the talks that you've heard today, all the things that we have is based on a lot of science. And there's a lot of people out there doing, YouTube videos and doing other things that has relatively poor science, right? So it's either animal trials or small case reports or this kind of thing. So this is still science, but it's poor evidence. Lifestyle medicine is based on some of the strongest evidence that there is available. Some of the best studies, some of the largest studies. And it used to be, so when Dr. Nedley and I were early in the lifestyle medicine movement, 10, 15, even 20 years ago, when we went and talked to other physicians, one of the first questions was, well, what's the science behind that? Now we basically don't get that question. The science behind lifestyle medicine is basically proven, it's well documented, and there's not a lot of controversy behind it. Basically everyone